I'm going to talk about ECMO in cardiac arrest and how we utilize that. We're going to talk about some of the important aspects that I hope you all will understand after today about ECMO. Some of the evidence that surrounds the use of ECMO for cardiac arrest and how we can be successful. And then Jeff is going to talk about operational considerations for the field and the hospital. But first, terminology. So y'all know what ECMO is, right? Extracorporeal membrane oxygenation. Y'all know what CPR is. We do it all the time. When you combine these two, it's actually called ECPR. And I need you to know this because at VCU and in other hospitals around the country, this is actually what ECMO in the setting of cardiac arrest is called. And so those words will be used interchangeably, and so I don't want any confusion from that. So what is ECMO? Well, there's a couple different ways we use ECMO. There is veno-venous, which is where we cannulate two veins and bypass the lungs or take over for the lungs. And then there is veno-arterial, or we take over for the heart and the lungs. This is where we cannulate an artery and a vein. For the purposes of cardiac arrest, we will always cannulate the femoral artery and the femoral vein. So here you have a very small simulation of what ECMO is. So if a patient comes in and they're in cardiac arrest and we're going to put them on ECMO, we will put a cannula that looks like this. It's very long and it's very wide. This is an 18 French catheter. We put up to 25 French catheters, so this is pretty small compared to some of the ones we use in the vein. We put this cannula in the femoral vein. It goes up the iliac vein into the IVC and it terminates at the right atrium. This cannula then sucks blood out of the venous system that is deoxygenated, and it puts it in through the circuit and into the pump. The pump then propels the blood through the oxygenator, where it removes carbon dioxide and it adds oxygen to the blood. Then, this oxygenated blood is going to go back into the body by a return or an infusion cannula, which is much shorter. This is your arterial cannula. Also 18 French, but they vary in size as well. This terminates in the iliac artery. It's much shorter, and it propels blood through the body. It actually sends blood all the way up the aortic arch and feeds the heart, the brain, and the upper extremities. So this system altogether provides support for the heart and the lungs. It does not provide support for the liver, the kidneys, or any other organ system. So for example, if someone is in fulminant liver failure from Tylenol overdose and experiences cardiac arrest, these patients would not benefit from ECMO because the liver is the problem, not the heart or the lungs. With that being said, I need you to understand that ECMO is a bridge. It is not a treatment. It is a bridge to something. It is a bridge for the patient to recover. It is a bridge for transplant. It is a bridge for LVAD placement. It does not treat any of the underlying conditions that these patients have. It only provides support. Support for the heart and the lungs. Which means these patients have to have something that's reversible. We have to be able to fix what they're coming in with. If we can't fix it, ECMO won't help. So, what does the evidence say? Why are we using ECMO for cardiac arrest? Well, in 2015, the TEAR trial was published. This was done in Australia at the Alfred Institute. They actually looked at in-hospital cardiac arrest and out-of-hospital cardiac arrest. But for the purposes of this conversation, I'm just going to talk about out-of-hospital cardiac arrest patients. They included an age of 18 to 65, a suspected cardiac etiology, CPR that commenced within 10 minutes, only VFib arrest patients, and they had to be able to have mechanical CPR. They had no exclusion criteria. However, patients with in-hospital cardiac arrest did exclude terminal illnesses such as stage 4 cancer or neurologic disability, end-stage renal disease. So my guess is that if any of that was known, then those patients would have been excluded. They, over the course of 32 months, had 11 out-of-hospital cardiac arrest patients that met their criteria. Pretty small number. Of those 11, 9 patients were cannulated for ECMO. 2 of them achieved ROSC prior to cannulation, so they did not go on pump. 5 of the 9 patients survived to hospital discharge neurologically intact, or 55% of patients cannulated. Some interesting facts about this is that of those 11 patients, 8 of them were found to have significant coronary artery disease. So again, that's your reversible condition in these patients. The median time from arrest to ECMO was 56 minutes. These statistics do include in-hospital cardiac arrest patients, so the time is probably a little quicker for this study, something to keep in mind. But they found that survival, for patients that survived, the time to ECMO was 40 minutes, whereas the time to ECMO for non-survivors was 78 minutes. That's a huge difference, and it tells us that time is really important in these patients. Also, the median time from the arrival of the ECMO team, or who's going to put these patients on ECMO, to the start of ECMO was 20 minutes, and it ranged from 15 to 30 minutes. So if you take into account the pre-hospital time, the time in the emergency department without ECMO, and the time it takes to cannulate, you're looking at a pretty significant chunk of time. And so the goal is, or what we need to do, is try and figure out how we can decrease the time to get these patients on pump as soon as we can. That way we can increase their survivability. So taking this into account, another study was published in Utah. They developed an ED ECMO program, and they talked about it. They had more extensive inclusion criteria. You can see just by looking at it, this was theirs. They had a smaller age range, it was age 18 to 60. They also had a suspected cardiac etiology. They required witnessed arrest and bystander CPR. Their patients could have VFib or BTAC. They had to be in arrest after 15 minutes of standard ACLS therapy. Their transport time had to be 10 minutes or less from where they were picking the patient up at. And ECMO had to commence within 90 minutes. They also had a lot of exclusion criteria. They excluded anyone who was thought to be in arrest from a non-cardiac cause, your brain bleed, your trauma patient. They excluded anyone with significant comorbidities that affected their daily living, patients on home oxygen, those with end-stage cancer, etc. And they excluded those with a pre-existing neurologic disability that was significant. And then those with a groin infection, because remember, we're putting all these cannulas in the femoral arteries and femoral veins, so an active groin infection, theoretically, you can see an infection to the rest of the body. So here's what happened at their facility. They had 15 pre-hospital ECMO alerts over the course of 6 months. Of these pre-hospital alerts, 8 patients were activated for ECMO. The 7 patients that were not activated was due to change in condition on EMS arrival or morbid obesity. 6 of the 8 patients were cannulated. The 2 that failed were due to morbid obesity. 3 of the 6 patients that were cannulated survived to hospital discharge, or 50%, neurologically intact. The final study that came out most recently is the one that is affecting pre-hospital ECMO and ED ECMO most. Minnesota put together a pre-hospital ECMO program. They had 3 different agencies that brought patients to their hospital. They bypassed the ER. They went to the cath lab. The cath lab was waiting for them to be cathed. It was a perfect setup. Their initial study published 27 patients. And then 3 months ago, they published another study, and they released statistics from the first 100 patients they cannulated. This is their inclusion criteria. They have a little bit of older patient population. They included age 18 to 75. Also a suspected cardiac etiology. They included only VFib and VTAC that is refractory to 3 shocks and amiodarone 300 milligrams. These patients had to fit in the Lucas and therefore get mechanical CPR. And their transport time to the cath lab had to be less than 30 minutes. This is their exclusion criteria, also quite extensive. If they got ROSC, they were obviously excluded. If they were from a SNF or a skilled nursing facility, they were excluded. DNR, DNI, obviously excluded. Any known terminal illness, again, excluded. Traumatic arrest, those in PEA or asystole, excluded. Any significant bleeding, and if we could only provide manual CPR, patients were excluded. This is their protocol. It's a little extensive, so I'm going to break it down. Patients who met transport criteria went to the cath lab. They had 100 patients come to the cath lab. As soon as they got there, they placed arterial access and venous access under ultrasound guidance, and they drew an ABG, an arterial blood gas. While they were waiting for the ABG to result, they looked at the vessels, the arterial, iliac, and femoral vessels, to see if a cannula could fit. Because if the cannula can't fit, what's the point in proceeding? And then they evaluated the time from arrest to the cath lab table. And then they got the ABG. Based on these results, they either proceeded or they declared the patient dead. So if the patient had one or more of the following, they declared the patient dead. If their end tidal was less than 10, if their oxygen level in the arterial blood was less than 50, if their lactic acid was greater than 18, and if the time from EMS activation to the cath lab table was more than 90 minutes, these patients were declared dead and resuscitation efforts were stopped. This excluded 8 patients. 92 patients moved on to receive full treatment, cannulation and cardiac catheterization, and then they evaluated for further cardiac interventions based on need. Prior to actual cannulation, 15 of these patients achieved ROSC, and therefore they did not cannulate, and they only placed an intra-aortic balloon pump. Of the patients who were on ECMO, they evaluated them for 90 minutes, and if the patient did not get return of cardiac function, they declared those patients dead. This included 9 more patients. 83 patients were admitted to the CICU based on this protocol, 68 of which were on ECMO. 15 got only the intra-aortic balloon pump. So to break it down a little bit better, they actually screened 292 patients over the course of 25 months. 147 of them got ROSC and were automatically excluded. 100 met transport criteria based on their inclusion and exclusion criteria. 92 met ECMO criteria, 68 were placed on ECMO, 15 with a balloon pump, and therefore 83 to the CICU. Of these 83 patients, 46 patients were discharged home. 6, unfortunately, had poor neurologic recovery. 40 survived neurologically intact, or 45.6% of patients. Some interesting facts about this study. Bystander CPR only occurred in 60 out of 83 patients. Significant coronary artery disease was found in 84 of the patients. And if you remember, 8 didn't even get the cath lab because they are excluded based on their ABG, which means really 84 out of 92 patients had significant coronary artery disease. Massive PE was found in 2. The first responder response time was 7.6 minutes on plus or minus 1.2 minutes from the time of the call to the time y'all were on scene. The time from 911 call to ECMO start was 65 minutes plus or minus 2.3 minutes. So there's a little wiggle room. They had pretty good stats with these numbers. But what are the keys to success? Taking all of this in, analyzing all of this data, how can we be successful here in Richmond? Well, preparation. That's why we're here today. We want you guys to know what we're doing, know why we're doing it. We're educating our doctors, we're educating our nurses, our medics. We're working with CT surgery, we're working with CICU. All of these things are being put in place so we can give our patients the best care we can. We're choosing the right patient. We're looking back at the selection criteria, the exclusion criteria, and seeing who fits the right criteria for pre-hospital cardiac arrest and ECMO. High quality CPR. Some of these studies only include mechanical CPR. We are not going to do that. But we do need high quality CPR, whether it's mechanical or it's manual. And time. Study after study shows that time is the most important factor in survivability. It is directly related to how quick you can get the patient on pump. So, at VCU, we would love to have these numbers. We need your help. We need your help to achieve these numbers because y'all are so instrumental in our patients' care. And that's what Jeff's going to talk to you about.
Thank you guys for being here. Recognize a lot of the folks in the room. I'm Jeff Ferguson, working in the emergency department with Angie down at VCU. I'm also the deputy medical director for Wright Fire, medical director for VSP MedFlight, and also Richmond Volunteer Rescue. So a few other jobs outside of VCU. We really wanted to get this out to the Metro Richmond area agencies as quickly as possible because we're really planning to kick this off April 1st. We've got several hospitals that have really bought in, and we're all agreeing to go live date on this. So the ODEMSA regional kickoff will be April 1st. It is April Fool's Day, right? So what we don't want to do is fumble this kickoff. So we're trying to get as much education, as much push out as we can. The protocol is out there. It's on the ODEMSA website. Please familiarize yourself with it. We've got less than a month to go. You guys are the key to the entire success of the program. Otherwise, we've done all this for nothing, and it will be a fumble, right, from the very get-go. So please familiarize yourself with it. So we'll get into the protocol. So it's going to be in your cardiology section, protocol 210, if you're using the regular ODEMSA website, our regular ODEMSA protocol, so you can find it there. These are the patient selection criteria. The age is 15 to 70 for ODEMSA. It needs to be a witness cardiac arrest. The total time from the assumed arrest time to the time you can deliver them to an ECMO center needs to be less than 30 minutes. And Angie talked about the need for us to have a little bit of time once you get to the emergency department to get them on pump. Cannulation is not exactly an easy thing to go through, so we need a little time. So the sooner they can get there, the better. But we've set the time for pre-hospital, out-of-hospital time from cardiac arrest at 30 minutes. No significant end-organ comorbidities such as end-stage renal disease, end-stage cancer, etc. Witness persistent VF or VT or recurrent VF with intermittent ROSC. So basically we're talking about VF or VT that doesn't want to go away. Either you shock it and it doesn't respond whatsoever, or they keep going back into ventricular dysrhythmia. Pulmonary embolism is in the inclusion criteria, and then a weight less than 140 kilos that roughly translates into 300 pounds. Okay? So those are all the things that have to be there for the inclusion criteria. Exclusion, they go greater than 5 minutes without CPR. So that kind of ties back into needing to be a witness cardiac arrest. If they're greater than 5 minutes downtime before the initiation of CPR, or there's more than a 5-minute break that you guys are aware of, we really shouldn't be cannulating those folks. Assistedly, either as an initial rhythm or as a presenting rhythm, they're not going to go on pump. If they can't get mechanical CPR or high-quality manual chest compressions, we know that we don't do great CPR in the back of a moving ambulance. It would have to be the mainstay of what you're doing. So disregarding almost all other therapies in order to focus on that, you're going to need multiple people in the back of the ambulance to trade out because your transport times probably exceed 2 minutes, which we know is kind of the break off of where people start to get tired. So you've got to have enough folks to swap compressions in the back of the ambulance, and you're going to that needs to be your primary focus when, just as it is now for beginning CPR, high quality CPR with little interruption. An unwitnessed arrest, so folks that go down on their own and then are found later, that's an exclusion criteria. And then we've kind of become a little redundant here, but any irreversible pre-existing conditions, and we've restated a lot of these: advanced malignancy, renal disease, or renal disease, and then neurologic disability. So folks that have baseline neuro problems that aren't great candidates for being discharged neurologically intact. If they're not neurologically intact before ECMO, they're not going to be neurologically intact afterwards, right? Anybody with an active DNR or folks coming from a skilled nursing facility. So nursing homes and skilled nursing facilities are going to be discounted. And then again, a little redundancy here. If they're over 140 kilos or 300 pounds, then again, as Angie mentioned, those folks are very difficult to cannulate, and that's the upper limits of where our CT surgeons in the region have agreed to try cannulation. That is a question that came up. I think if they're there for a very clear reason and a reversible reason, I would say that we would include them. And I think certainly in conversations with our folks at VCU, yes, Initially, this was built off of hours, but then that came up and the answer was sure. If they're there for a knee replacement and just there for PT and rehab for a few weeks before they go home, we're not gonna kick those folks out. This is more dedicated, sort of institutionalized folks, because those folks are certainly going to be an increased risk for the PD. That's a great question. Thank you. There's a little discrepancy here. I would say signs of puberty are good. Appearing stated age, or whatever their age appears to be. If you go on signs of puberty, probably 15 is a reasonable choice. And for 70, it's going to be a pretty good guess, right? And I would certainly recommend, depending on the protocol you guys have, if you're using the ODEMSA, this probably needs to be printed, laminated, and a hang tag on your monitor, okay? Somewhere immediately accessible so you can kind of run this list. So let's talk about the hospitals that have said they will step up and participate in the regional ECMO initiative. From HCA, we have Chippenham Medical Center, Henrico Doctors Hospital Forest, Bon Secours St. Mary's, and Bon Secours Memorial Regional Medical Center, MRMC. And then, of course, VCU, we have our hospital downtown. So I've put these guys on a map for you. Depending on where you are when you encounter the cardiac arrest and how fast you drive and how fast you can get on scene, it's possible, okay? And I'll show that to you in a few seconds here. But for the hospitals that are included, starting from the south here, Chippenham, we've got Henrico Doctors Forest, St. Mary's, VCU, and MRMC. So you guys are all familiar with those hospitals. So that's kind of where they are. This is from the Hospital Coalition here with an overlay of not only the hospitals, but the county lines. So our HCA hospitals, Chip and Forest, cover there. Bon Secours, St. Mary's, and MRMC, and then VCU. I chose a 10-mile radius because that's probably the sweet spot. Gives you a few minutes to work your arrest on scene, get off scene, get mobile, and head to one of the ECMO centers. There's a lot of overlap, but that overlap covers the city, right? So a 10-mile radius within the city doesn't really make sense unless you find a way to drive 60 miles an hour in the city. But some of these further out, you may be able to get into the hospital within 30 minutes if you're close to the interstate. If you expand this out, I tried it today with Google Maps and the traffic conditions. At about 3 o'clock this afternoon, we could get to VCU from the county line, New Kent, James or Charles City County, and Henrico. You could get from there to VCU in 20 minutes. So if you spend less than 10 minutes on scene, it's going to be tight, right? So this is something you're going to need to pre-plan with your agency, with your department, about what's your closest. If you have more than one, what's going to be your decision maker, and sort of draw your own boundaries. This is the written protocol for ODEMSA. This is literally where the rubber is going to meet the road, okay? And there's a lot of words on here, so I'm just going to break it down. So we want you to do your initial assessment, recognition of a shockable rhythm, a single shock, okay? One shock on scene. If there's a persistent shockable rhythm or a recurrent shockable rhythm, continue ACLS guidelines as normal, follow your protocols, but we want you to do them en route, okay? And that's 180 degrees for me. I got a standing ovation at EMS Symposium in 2008 for saying I wanted to stop transporting dead people to the hospital, okay? Anybody remember that whole fight? In the past 10 years, we've done a great job of beginning to work people on scene and work them either to ROSC or to cessation of efforts, right? Now we're saying, we're asking you guys to throw them in the truck as soon as possible and transport them. So we understand that it's a complete shift in what we've taught you, but it is only for a select small group of people. So being able to identify those folks early, make the decision to get them off scene and after one shot, okay? If it's a suspected pulmonary embolus, continue your resuscitation per guidelines. We want you to maintain mechanical chest compressions or high-quality chest compressions throughout transport. Let us know you're coming, okay? Just like STEMI, excuse me, just like stroke, the earlier you make that call, the more prepared we're going to be. As Dr. Creditt mentioned, preparation's a big deal, right? If you don't call until you're 5 minutes away, we're not going to have the team assembled, okay? And we'll talk about the steps that we're going to go through at VCU, and you'll see how sort of the cascade. It's not going to be a one call and everybody comes running. There's several things that have to happen within the hospital in order to make this happen. So please, as soon as you're on your way, let us know. And even if you get your driver to say we're on your way with an ECMO candidate, at least we'll have the ability to get our doctor ready to talk to you guys when you call in with a better report. Okay, so early notification, please. And then head to an ECMO capable hospital. So early CPR, early recognition, a single defibrillation, okay? That's it on scene, that's all we want. We want mechanical or high quality CPR and move the ambulance as fast as possible, okay? Everything else needs to be done en route and moved to ECMO, okay? That's the entire protocol in basically 3 steps. We are from VCU. Everything up till now has been as Switzerland as I can make it, but you know, we do want to talk about what we've got going on. You guys have seen our resuscitation bay. Does anybody know this guy? Most of you guys have heard him speak, I'm sure, and it's a legendary story. On April 1st, 4 years ago, Joe was on ECMO. So it's pretty amazing to think that in 4 years we've been able to bring the entire region up to speed, and I'm not saying VCU did that, but the region continued to push this effort forward and have really overcome a lot of hurdles to basically provide the care that Joe got that day that truly saved his life, and now we're offering it to most of the Metro Richmond area. Pretty awesome. So now I got to make fun of the ODEMSA protocol a little bit because can anybody memorize this? No, it's right. Your eyes cross or go in opposite directions, trying to go back and forth between the two. We've actually boiled it down a little bit, and I'm hoping that we can get the region to move towards this to a quick checklist. And the ages may change. Age 18 to 70, witness VF, persistent VT, or PEA arrest. Time without CPR less than 5 minutes, estimated weight less than 300 pounds, no terminal illnesses, and arrest time less than 30 minutes, including the transport time. And we're high quality chest compressions continuous once EMS arrive, okay? That covers all but I think one of the inclusion and exclusion criteria. And the nice thing about this is that the answer to all of these questions are yes, you're good to go. Okay, so that's probably what you're going to need to say if you call into VCU. We've listed our comm room number here. Tell the medic you've got a possible ECMO patient, and then move as quickly and safely as you can to the ED at VCU. Sure, please do.
Just a quick comment on the PEA. That's not been an inclusion criteria for studies previously. And CT surgery, in having conversation with them, they have had some success with patients who have PEA arrest, mostly with PE. So you still have to have a high level suspicion that this is a reversible cause, either cardiac, MI, or PE. We are, at VCU, including these patients somewhat hesitantly because there's a lot of patients that have PEA arrest. So I just want y'all to be aware that we are including them initially to try and better assess this specific population so that we can take care of our PE patients. And then we will evaluate those cases as they come in and refine and be better.
This is a moving target. The initial criteria that we worked on for the ODEMSA protocol, probably at the end of the year last year, they've changed 3 times since then, and this actually represents a 4th change. So it is a moving target, so bear with us. The science is changing. Our regional tolerance for alerts is going to change, and then once we start doing it and seeing how we're doing, those cases and that information will probably power further change down the road. This is what our internal process is going to look like. So at out-of-hospital cardiac arrest, the screening that you guys do, if the answer to any of those questions is no, continue your usual protocol, transport according to your protocol. Okay? If you think the patient needs to be transported based on your current guideline, then do. Otherwise, continue to work them on scene like you're doing currently. If the answer to all of those is yes, then please call the comm room as soon as possible. That call is going to be patched through to the attending in charge. Okay, you're going to talk to a physician and tell them exactly what you've got. Okay, and very succinct. Even if you just say run this list, and they shouldn't be asking you a ton of questions back. Okay, we realize your time is valuable, and you're kind of busy doing other things like CPR. So that puts the ball in motion. That attending physician is going to call the attending CT surgery. Okay, so we're going straight to the top. We're not making multiple phone calls to residents who play the telephone game along the way up. This is attending in the ED, talking to the attending in CT surgery and saying yes, no. If they are available, then we identified them to be an ECMO candidate, then we move on to the next page. If not, we're going to continue, bring them in anyway. We're going to continue ACLS, okay? And we'll continue to work the code just like we would normally. But I hope you guys understand, because of all the other exclusion criteria, logistics, availability, there will be people that come in that you think are great candidates that are not going to get cannulated. And that can't be the expectation that 100% of those folks get cannulated. In all of those studies, people made it to the ED and didn't go on pump for one reason or another. So please be accepting that that's the fact. And we know that you guys are going to try your hardest and work your hardest, and we'll appreciate the sweat, blood, and tears that you guys put into these patients, but understand that not all of them will go on pump regardless of which hospital you go to. But if they are a great candidate or a good candidate, then preparation will begin even before the patient arrives. A pump alert will be called. This is going to bring the team downstairs. The emergency department is going to take over for you guys, and our job is to continue ACLS while the CT surgery folks handle the middle column here. If for whatever reason CT surgery is in the operating room, then the emergency department will start placing those lines, not the ones that you guys see, but smaller ones that can be upgraded. This is also something else that we're moving to the point that we hope in the near future some of our emergency physicians will be doing the actual ECMO cannulations. Once they're cannulated in the ED, they go on pump, they go to wherever the place that will fix the reversible problem is. Okay, if we're talking about a PE, they may go to the operating room, they may go to interventional radiology. If it's a STEMI and the problem is cardiac, then they'll go to the cath lab. If it's some other cause, then they may go directly to the ICU and bypass the OR to the cath lab. So it really depends on what we think the reversible cause is and where they land. And we put the exclusion criteria, and again, this is the in-hospital one. I'm being as transparent as possible with you guys. The exclusion criteria are still there, and really it only takes one link in that chain to say this is a no-go, and we'll have to cancel the idea of cannulating. Any questions at all about what we've talked about? To my knowledge, the 5 that have said yes are planning to offer 24/7 availability. But this really does depend on you guys. If it's going to be successful, identifying the right folks, quick on scene, high quality CPR on the way in. Okay. The question was, if we apply the inclusion and exclusion criteria to the population that get cannulated in the emergency department and have 50% neurologic recovery, how many of those folks would have had normal neurologic function at the point of discharge if they only got ACLS in the field? The assumption is, with recurrent VFib, VTAC, that at some point they would have progressed to a systole and the code would have been called. So our assumption is, with a few outliers, that all of those folks would have died. So the fact that we're even talking about 20, 30, 40, 50% saves on folks that would have otherwise been called in the field, that's what makes all this worthwhile. Yes, yes. They're the critical part of the team, and once the pump alert's called, they'll be coming down and bringing the pump down. You can give us an update if you have time, but like I said, we don't expect any further information. If you arrive and your patient has decompensated from VFib, VTAC to asystole during the time of your transport, no harm, no foul. We understand there's going to be some false positive or false positive activations. It's just in the nature of the beast, right? It's an uncertain art. Great questions, guys. Really appreciate your time and attention. Hopefully it was worthwhile. If anybody wants to look up and read all the literature, Angie's included all the references for her slides. Mine are easy. It's ODEMSA and the internal protocol. So I didn't put mine up there, but we can provide that if you're interested. We've created this email address, vcuems@vcuhealth.org. If anybody has any EMS-related questions, patients that they'd like to follow up, this goes to a select group of EMS physicians and Greg. We're happy to answer anything. We can loop in the CTCCE if there is need for classes that you guys identify. Anything at all EMS related, we're happy to help. Thank you guys.
Thank you.